for attending, and sorry for the short notice. Okay, so today I'm going to talk about sedation in the ICU. So this is a 60-year-old man admitted to the emergency with a history of fever, cough, shortness of breath for several days. Suddenly in the emergency department, the patient started to become tachypnic, shocked. He started to develop respiratory failure and had to be intubated and put on the mechanical ventilator. Just an illustration to see the intubation. So it's a tube that goes down the throat like this. Now, during intubation, the patient was given fentanyl for analgesia, he was given midazolam for sedation, and rocuronium as a neuromuscular blocker. Post-intubation, the patient was given fentanyl for analgesia. The infusion was increased to 100 mcg per hour, but the patient is still fighting the ventilator and is agitated. So what should come next? So we're going to talk about sedation now. At the end of this lecture, these are the learning objectives that you should recognize. The etiology of agitation and indications of sedation in critically ill patients, comprehend the importance of sedation and list the consequences of insufficient and over-sedation, describe different sedation scores and determine target scores, distinguish the different pharmacological agents used in sedation and compare the pros and cons, comprehend the preferred sedative agents, and outline a sedation therapeutic plan for patients. This lecture is going to be divided into 3 parts: strategy for sedation, pharmacological agents used for sedation, and suggested protocol. Now, should sedation be the first-line therapy for agitated patients? Do you think?
No.
No? Yes. So there's so many reasons of agitation in the ICU. Mainly, they are anxiety for a traumatic experience, MI, stroke, dyspnea. Mainly, pain is one of the main causes of agitation in the ICU, especially in patients with burns, trauma, and secondary to painful procedures in the ICU, such as arterial blood gas withdrawal and intubation. Delirium can also be a cause for agitation, either as a result of a psychotic disease or ICU delirium. There's so many other reasons for agitation, such as hypoxia, hypoglycemia, hypertension. We have to really look into the cause for agitation for the patient, because if you solve that, then you may not need sedation at the end of the day. For example, we had one of our patients who was very agitated because we found out that he was really hypoxic. Once we solved that, we did not need sedation. Now, it is very important to adequately treat 2 situations before starting sedation. These are pain and delirium. So we're going to start with pain. 82% of patients who were intubated remembered pain in the ICU. 38% recall that pain was their most traumatic memory from the ICU. And we have to note that sedation does not cause analgesia. Now, for pain, ICU patients reported significant pain even if there is no procedure involved. 50 to 80% of ICU patients report that their pain was not controlled. For pain control in the ICU, the first-line therapy is IV opioids. Now, acute pain is very important to control because it may lead later to chronic pain and even post-traumatic stress disorder. Now, there's so many pain scores, such as the Wong-Banker and the numeric pain score, but what if your patient is unresponsive and is on the mechanical ventilator like our patient? So in the ICU, the SCCM guidelines recommend the critical pain observation tool, CPOT. So this is a score that consists of 5 components that assess pain in critically ill patients or unresponsive patients. 1 is facial expression, body movement, compliance with the ventilator, is he fighting the ventilator, vocalization, if the patient has pain, maybe there's some sound that he's producing, muscle tension or muscle rigidity. And at the end of the day, your target pain score should be between 0 and 1. So mostly absence of all of these. Now, the other condition is delirium. So delirium is defined by the SCCM as acute onset of cerebral dysfunction with change or fluctuation in mental status. So delirium can come in many forms, hyperactive or hypoactive. The hyperactive one is the one associated with agitation. So we have to exclude delirium before starting sedation. And this is very important because some of the sedative agents can actually worsen delirium, such as benzodiazepines and propofol. Now, delirium affects 80% of mechanically ventilated patients. It has a very huge cost burden on patients. May increase mortality, causes prolonged ICU and hospital stay, and may even lead to post-ICU cognitive impairment. Now, there's so many risk factors associated with delirium. Some of them are ICU related and some of them are non-ICU related. Now, it is very important to assess delirium in patients in the ICU using this score, Confusion Assessment Method in ICU, CAM-ICU. This is the approved score by the SCCM guidelines to assess for delirium. Delirium should be monitored daily, and it works simultaneously with the RASS score. So even if the patient is very agitated, his RASS is very high, or the sedation score is very high, then you have to also assess for delirium. This score has 4 features: alteration in mental status, inattention, RASS other than 0, and disorganized thinking. It's a yes or no score. If the patient has any one of those, then he will be labeled as having delirium. There is no method there's no recommendation for prophylaxis of delirium, but there are other things to treat delirium like haloperidol and quetiapine and antipsychotics. But this is out of the scope of this lecture. Now, these are the indications for sedation: physiological, neurological, psychological, behavior, and the use of neuromuscular blocking agents. Now, physiological sedation can reduce oxygen demand. It can blunt central hyperventilation, improve compliance to the mechanical ventilator, and decrease dyspnea. Neurological, it reduces intracranial pressure in traumatic brain injury, and it's helpful in refractory status epilepticus, but it has to be combined with an antiepileptic. Psychological, reduces pain and discomfort, reduces psychological trauma, and the incidence of PTSD. Sedation can also be used to control agitation, especially in patients with traumatic brain injury, intoxication, and drug withdrawal. Now, all of the past indications, we can target light sedation. But when we are using neuromuscular blocking agents, sometimes we're using NMBs for conditions like acute respiratory distress syndrome, where the patient has to be on a neuromuscular blocking agents for about 24 hours. It is very important to achieve deep sedation when the patient is on NMB, because it's a very frightening situation where the patient would be paralyzed and awake. Does that make sense? Okay. Now, how much is too much sedation? Sedation should be balanced, which means that we don't need too much sedation, and we definitely don't want insufficient sedation. So insufficient sedation can lead to many complications such as agitation, incompliance with the ventilator, removal of the devices, especially the tube, increased sympathetic activity, hypercatabolism, recall. They have a higher risk for developing delirium and high risk for developing PTSD. Now, oversedation can cause increased duration in the mechanical ventilator, prolonged ICU stay, increased complications, inability to evaluate the conscious level, and more importantly, inability to detect any deterioration in the conscious level. And of course, oversedation will lead to dependence and withdrawal symptoms. So what is our guide here? So the SCCM guidelines, Society of Critical Care Medicine, recommends 2 scores: the Richmond Agitation Sedation Scale and the Riker Scale, SAS. It is recommended to have an hourly assessment for sedation. It is very important to target light sedation rather than deep sedation, except if the patient is on neuromuscular blocking agents. Now, this is the Richmond Agitation Sedation Scale. It's from -5, unarousable, to +4, combative or dangerous. And this is our score. This is our target score. So mainly here, alert and calm, or drowsy, or light sedation. We can accept that the patient can be a little bit anxious. Okay. Sedation agitation score, the Riker score, and this is the target sedation, between calm and cooperative and sedated, but not unarousable or not violent. Now, they have been using the Ramsey sedation scale, but this is not recommended anymore by the guidelines. Now, studies have shown that there is no difference between the Riker and the Richmond scale, so any one of them can be used. However, the RASS, I've noticed that it has been used more in the literature and research. Now this comes to the second part of our lecture, which is the pharmacological agents. So when we initiate sedation, we go in this direction. So we start with sedative analgesia, and then dexmedetomidine propofol, the non-benzodiazepines, and then the benzodiazepines. So these are the sedative properties in comparison between benzo, propofol, and dexmed. As you can notice here, benzo and propofol can have an analgesic effect, anticonvulsant, and dexmed has an analgesic effect. But please note that dexmed has a weak analgesic effect, cannot work on its own as an analgesic agent. Now, this is the pharmacokinetics. We're going to look into this. Now, opioids. So opioids are the first line to be used for pain in critically ill patients, as recommended by the guidelines. It is also recommended to try and change opiates to avoid dependence and withdrawal symptoms. And important ADRs to look out for is that opioids can accumulate in advanced age, renal, and hepatic impairment, can cause respiratory depression, constipation, nausea and vomiting, sedation, which in our case will be favorable, urinary retention, dependence, and withdrawal, and then that will lead to also delirium. Now, this table is just to compare and contrast fentanyl and remifentanil. So sometimes remifentanil will be, so according to this table, remifentanil may be preferred because it has a shorter T-half. So remifentanil has a T-half of 3 to 10 minutes compared to 2 to 4 hours with fentanyl. So the advantage of that is that it may have rapid recovery, but rapid also, it can cause withdrawal if there's any interruption in the infusion. We have to also note that fentanyl is metabolized through the liver, and this is why remifentanil, on the other hand, can be metabolized rapidly via blood and tissue esterase, so it is safe in hepatic impairment. So that's why remifentanil will be preferred in a patient with hepatic impairment. Also, fentanyl has a higher risk of drug interactions, such as causing serotonin syndrome with, for example, linezolid or any of the MAO inhibitors. So when to switch from fentanyl to remifentanil, in your opinion? Hepatic impairment? Before weaning?
So maybe if there is risk for serotonergic.
Yes.
With multiple serotonergic drugs.
Yes.
Multiple. Not so much.
If there's any studies that show decreased clinical ventilation days or the ICU length of stay when they compared fentanyl versus remifentanil?
I haven't looked into the evidence of that, so I mean, I'm going to look into that. Okay. So advantages of sedative analgesia is that it's the first line for agitation that is secondary to pain, but not for agitation that is not associated with pain. Disadvantage is that we may need higher doses, may cause respiratory depression, withdrawal symptoms, and other side effects related to benzodiazepines, to opiates. So the clinical product here is that it's the first line in patients whose primary cause of agitation is pain, especially in trauma and burns patients. Now, the second part of the pharmacological agent, dexmed and propofol. So dexmed is an alpha-2 receptor agonist, and the initial dose of dexmed will depend on the RASS score. So if the RASS is too high, then we're going to start with a higher dose. And if the RASS is not so high, for example, starting from +2, then we're not going to start with a higher dose. So the range is 0.2 to 0.6 mic per kg per hour. Now the dose range is between 0.2 to 1.5. However, there has been an off-label use of up to 2.5 mic per kg per hour. It is very important to remember that we should avoid IV loading dose in dexmed because it was associated with high risk of bradycardia and hypertension. Dexmed should be titrated on a longer interval, every 30 minutes, and and increased by 0.2 to 0.4 until light sedation is obtained. When Dexmed is used longer than 7 days, it may lead to dependence and withdrawal, and it has been shown that clonidine can be used as a treatment for withdrawal of Dexmed. So when do you think we should use Dexmed as a first line?
Weaning for the patient.
Weaning, yes. Non-ventilated patients. Okay. So the advantage of Dexmed, patients are easily arousable. It achieves light sedation. It never achieves deep sedation. Has minimal respiratory depression effects. It has an analgesic effect, but as I said, it's a weak analgesic effect. It may have opioid sparing effect due to its analgesic property. Disadvantage of Dexmed include bradycardia, hypotension, sometimes loss of oropharyngeal muscle tone, and so it can cause hypoxia in some of the non-intubated patients. And there is no really clear data about prolonged use of Dexmed. So it's approved for 24 hours. It has been used in the, shown effective up to 7 days, but no longer than that.
Sarah,
Now, yes.
You got advantages. You mentioned minimal respiratory depression, but then on the advantages requires respiratory monitoring.
Yes, it meets monitoring in non-intubated patients because it causes this oropharyngeal muscle, reduces the muscle tone.
So it's for the
But generally, it has the least respiratory depression side effect compared to the other sedative agents. Okay. So Dexmed can be used in patients. So it's the first line for patients who have both delirium and patients who need sedation, require sedation, and also have delirium. Can be used for patients for alcohol withdrawal. It can be used as a bridge for extubation. And this was the original approved indication for Dexmed. It's very important to remember that IV loading dose should not be used. May cause bradycardia, should be avoided in heart block, and not for deep sedation. Definitely not for deep sedation, and definitely not for patients who are neuromuscular blocking agents. Now, propofol is a short-acting lipophilic intravenous general anesthetic. It has global CNS depression through agonism of GABA and NMDA receptor blocking. It also decreases the beta-2 adrenergic receptor response, and this is important. We'll see why these advantages. The initial dose should be 5 mic per kg per minute or 0.3 milligrams per kg per hour. It is recommended to also avoid loading dose in propofol, but it's titrated much easier every 5 to 10 minutes. So when would you use propofol as a first line? Deep sedation.
Hemodynamic stable.
Stable. Yes.
Hemodynamic
Okay.
post-intubation.
So propofol has a short half-life. It is very safe in renal, and it has absolutely no renal or hepatic, it does not need renal or hepatic adjustment. However, the propofol is a lipid base, and the 1% preparation has 1 kilocalorie per ml. So you're going to have to subtract the calories taken from the propofol if you're preparing TPN or calculating nutrition for a patient. May cause hypotension, and it has a direct cardiac depressive effect. It's also substrate for several CYP enzymes, and it may cause propofol syndrome in higher dose, as we're going to see in the next slide. Propofol may lead to elevated triglycerides, and it should be avoided in higher doses. And it's very important to remember that propofol should be avoided in acute liver failure and in pancreatitis. Now, I'm going to talk about propofol-related infusion syndrome, PRIS. This is a rare but life-threatening condition. It happens mainly in doses exceeding 50 mic per kg per minute or 3 milligram per kg per hour for more than 48 hours. It may lead to accumulation of ketones, lactate, and disruption of mitochondrial respiratory chain. The clinical manifestations include metabolic acidosis, acute renal failure, cardiac failure, rhabdomyolysis, myoglobinemia, myoglobinuria, hyperkalemia, and so on. Some of the risk factors for PRIS are decreased oxygen delivery, neurologic injury, sepsis, vasoactive agents, acute liver failure, and pancreatitis. There is no definitive treatment for PRIS. It's a life-threatening condition, but hemodialysis may improve outcomes, and cardiorespiratory support can be used in PRIS syndrome. Now the third part, we're going to talk about benzodiazepines. So mainly we're using midazolam. It binds to the stereospecific benzodiazepine receptors in the postsynaptic GABA neuron. The initial dose should be 0.1 to 0.05 milligram per kg, which should be repeated every 5 to 15 minutes until sedation is attained. Sorry. And titration is, we're using bolus doses. So it depends on the level of agitation. If it's mild agitation, then we're just going to use 1 to 2 milligrams, and if it's severe, it's going to be 2 to 5. And depending on the number of bolus doses, we're going to determine how are we going to change the infusion rate for midazolam. Now this is a comparison between midazolam and lorazepam. Lorazepam mainly is the drug of choice in there for alcohol withdrawal. You just have to be careful with the lorazepam that it's not recommended in renal failure because of the glycotoxicity that can occur. So benzodiazepines. The take-home message is that it has an immunogenic effect, it achieves deep sedation, can be used for seizures. However, it is very risky to use with advanced age, renal impairment, may cause withdrawal, and it has an increased risk of delirium as well compared to other agents like example dexmedetomidine. It is not the preferred agent to use for sedation according to the guidelines. Now, which agents are best to use? Depends on the patient. What does the evidence tell us? So this is the MIDEX and PRODEX trial. So the PRODEX compared propofol versus dexmedetomidine, and the MIDEX trial compared midazolam versus dexmedetomidine. They are both randomized controlled trials, multi-centered. The MIDEX was in 44 centers across Europe, PRODEX 31 centers across Europe and Russia. It was a blinded double dummy, and the duration was 3 years. The medication duration was up to only 14 days, and patients were followed up 45 days after discharge. Sedation score was from 0 to -3. Inclusion criteria was mechanical ventilation that required light sedation, and exclusion criteria was acute severe neurological disorder and heart block. There are 2 outcomes. One was the time to sedation, and the secondary outcome is the ICU length of stay and mechanical ventilation duration. This is a sample of the results. So there was no difference between, in terms of time to sedation. Only in the MIDEX trial, the dexmedetomidine had less stay on the mechanical ventilation, which was statistically significant, but not in the PRODEX. There was no difference in the ICU length of stay. And it was noted that patient interaction was much better in the dexmedetomidine arm in both studies. And RAS was also higher in the dexmed arm in both studies. There's some limitations to this trial. More bradycardia was seen with dexmedetomidine. This study, they used standard sedation prior to randomization, so patients did receive other sedative agents before getting the intervention or the control, being randomized into the intervention or control group. There was no scheduled sedation vacation. Weaning from the mechanical ventilation was not standardized. It was a non-inferiority study, and they were using median and interquartile range for continuous data, which is not appropriate. Now, there's 3 important aspects to consider during sedation. These are sedation vacation, early ambulation, and proper sleep. Now, sedation vacation is just holding the sedative agents for a few minutes. It should be done daily, or ideally every shift. And when the medication is held, a neurological exam has to be done, and glucose care has to be calculated. Now, sedation interruption is recommended by the SCCM guidelines, even if the patient is on light sedation. It shortens the duration of the mechanical ventilator, it decreases the length of stay in the ICU, and encourages encourages early ambulation. Now, early ambulation is highly recommended by the SCCM guidelines. It is best strategy to avoid complications from oversedation and reduces the risk of delirium. Now, the guidelines also recommend that sufficient sleep has to be encouraged in the ICU. It decreases the risk of delirium, so several hours of uninterrupted sleep are recommended. That can be achieved by reducing blood works in the night shift, controlling the environment, controlling the lights, using earplugs, sometimes using melatonin. In the ICU, there's a lot of evidence about melatonin, and using trazodone or zolpidem. Now, it is very important to implement a sedation protocol in the ICU. So, a recent systematic review included studies that examined the impact of the sedation protocol in the ICU, and it has shown that it has improved practice, maintained optimum sedation target, improved patient outcomes, and optimized resource usage, so basically less cost. Now, the pharmacist is an integral part of the healthcare team in the ICU. It plays an essential role in the choice, titration, and administration of sedative agents in the critical care. There was a study that was conducted in 2008, compared before and after implementing clinical pharmacy and after implementing clinical pharmacy in the two ICU units, 156 mechanically ventilated patients. It was shown that when a pharmacist was involved, he enforced sedation protocol, improved the protocol adherence, and decreased the length of the mechanical ventilator. These were the results. So, can we just have a little light? I'm going to read this out. So, the duration of the mechanical ventilator was statistically significant. The ICU length of stay and the hospital length of stay were all statistically significant. Yeah.
Actually, there was a very nice article about the hospital in Florida. Pharmacists took charge of the whole sedation protocol in the ICU, and they showed that they saved up to $1 million for the hospital patients. And there was a trend toward decreased mortality in the arm where the pharmacist was taking care of the sedation. It was in the SHP award section. They won the SHP award or something.
So, in summary, agitation can occur in the ICU for several reasons that must be addressed before initiating sedation. Sedation is a cornerstone therapy that is used in the critical care, and you don't want to undersedate your patients or oversedate your patients, because both of them can lead to complications. There are two approved scores by the guidelines, the Richmond and the Riker. There are three main agents for sedation: the propofol, Dexmed, and midazolam. Have to remember that propofol may cause hypertension, should be avoided in acute liver failure and pancreatitis. Dexmed may cause bradycardia, should not be used for deep sedation, only light sedation. And midazolam is your last resort, last option for sedating patients in the ICU. Propofol and Dexmed proved to be equivalent, but they are both superior to midazolam according to the MIDEX and the PRODEX trial. We don't have anything comparing propofol and Dexmed. They proved to be equivalent in the PRODEX trial. So for our patient, Dexmed was started for him. So the RAS was positive 3, and therefore the Dexmed was started at 0.4 micro per kg per hour, as per the hospital protocol. The dose was titrated after 10 minutes to 0.06. Afterwards, the patient was well sedated, and then he improved, was extubated from the mechanical ventilator, and shifted to the medical ward. Now, finally, I want to conclude with a video that ICU professionals should see, and pharmacists should also see. This is a real-life experience from one of the patients who was in the ICU.
I woke up in intensive care. My eyes were swollen shut, I couldn't see. My jaw was wired closed, and there was a hole in my throat, so I couldn't eat, I couldn't through all the noises of a busy intensive care unit for any sign about what was happening or likely to happen to me. And then a machine would beep loudly. I couldn't see, and I didn't know what it was, and I thought that maybe I was going to die. But somebody would come and they would reset the alarm and move away silently. The doctors would come around the bed and they would discuss my case in great detail with each other in a language that I didn't understand. And then they too would just quietly go away. And at night, nurses would come and they would attend to the IV lines that fed and hydrated and medicated me, and they would take notes, I suppose, and read things. And they attended to my physical needs with skill deficiency, but they never saw, they never acknowledged my emotional needs.
Okay, so this video just explains that it is very important to, ICU can be a very traumatic experience for our patients, and it's very important to properly have proper analgesia and sedation for our patients. And by this I conclude my lecture. Thank you very much for attending. Questions, please. Yes.
Thank you, Dr. Sarah, for the presentation.
Thank you.
I have a question regarding the comparison of hemofentanyl and fentanyl in terms of serotonin syndrome.
Yeah.
Is there any evidence of difference between remifentanil and fentanyl in terms of serotonin syndrome?
I haven't looked at that in detail, so
Mm.
I'm going to have to look at the evidence and come back to you on that.
But it happened before. With linezolid 2 times.
With remifentanil?
With fentanyl.
With fentanyl, yes, but not remifentanil.
It was mentioned that remifentanil may be an alternative if the patient is in another serotonergic agent.
Yes.
So is there any evidence supporting this?
See.
Actually, this is very used here commonly, and I think this is not right.
Actually, the diagnosis, I think the diagnosis of serotonin syndrome in the ICU is overrated. Because usually if you have a patient in the ICU, maybe you are not sedating your patient well enough, so the patient is in anxiety, is tachycardic, is hypertensive, and you go ahead and diagnose the patient as serotonin syndrome. No, it's a very rare condition to get a serotonin syndrome.
Yes.
And you can treat it symptomatically.
I mean, if there is any preference for any of
I don't think there is.
another question regarding the use of benzodiazepines. Which strategies preferred, the bolus doses or the continuous infusion doses?
So
Because
for
you
the-
mentioned that can be
Yes.
used by.
So for the midazolam, you're maintaining the patient on continuous infusion.
Mm.
But if the patient is agitated, you can use bolus doses. And then according to how many bolus doses did you need for the patient in a certain period of time, then you change the rate of infusion of midazolam.
Mm.
This is not in the guidelines, but I've looked into many protocols by many other ones. There's no solid evidence about this, or I haven't found anything, but yes, you can use bolus doses for agitation, depending on the level of agitation. Is it mild or is it severe? And then you change the rate of the infusion depending on how many bolus doses did you use for midazolam, instead of just increasing the rate.
Because I was thinking that using bolus doses may decrease the requirements and decrease the level of sedation, the over sedation.
Actually, there's some
But
studies
if you-
showed that the boluses better than the continuous infusion. I read some studies about giving frequent boluses better than give continuous infusion.
Because usually this is not the practice in most of the ICU.
Yes, it's just give infusion.
Mm.
Yeah, they just increase the rate, but if you're giving bolus and it works just one time, then you can just keep the infusion at the same rate.
But the problem.
But if you're using too many boluses, then that means you're not
If
adequately
your
sedating your
patient
patient.
is comfortable,
No, the problem is the nurse.
not
Need
the
dedicated nurses to watch the patient need like this.
I
Dedicated nurse.
don't believe in the initial stabilization phase of the patient you can give boluses. You just need to start the patient on infusion and upgrade titrate up.
There is some studies now start to talk about give bonuses, but the problem is dedicated nurse.
That's not that. That's not.
Sometimes the nurses are not reporting the oversedation.
And
They're
what-
reporting the undersedation because they're not happy. Not reporting the oversedation.
What about ketamine?
Well,
The sedating agent.
well, it's not. There isn't anything about it in the guidelines for sedation, but there is evidence about. I've been asked about this before. So ketamine, there is evidence about it in procedural sedation,
Yeah.
in combination with propofol versus modafinil or fentanyl. But I haven't found anything about ketamine as a continuous infusion sedation for patients who are on mechanical ventilator.
Because you use it in anesthesia. So.
Anesthesia, yes, but so how? I'm not really sure about the efficacy and safety of this on a prolonged period of time.
The last question regarding the effect on hemodynamics. Usually we say that propofol is, the effect on blood pressure is higher than the others.
Right.
Is there any, direct comparison of these agents in terms of hemodynamics?
In the Prodex trial, there was just more bradycardia
Yes, but I mean,
with the dexamethasone.
hypotension.
But hypotension,
I read one study
Probably
before,
not.
yes, about dexmet versus propofol, and show more hypotension with dex.
with dexamethasone.
More hypotension.
Usually there's some more.
Thank you.
So it's a comment rather than. So for the mid-milligram doses,
Yeah,
refractory seizures usually use should be much
higher doses in seizures, yes. But in sedation, just
Yeah.
ICU sedation, this is the recommendation.
Thank you very much.
Any other questions?
Okay, Sarah, thank you. Great presentation.
Thank you.
I guess my question is the romafentanil. I'll go back to what Muhammad was asking. Obviously, the onset of action is, like you said, 5 to 10 minutes or something, or is that was that the half-life or was it the onset?
So the half-life is a lot less than fentanyl.
Okay, so would that be a concern as far as dosing? Because if it's going to be such a short time frame, does that mean that you're going to have to
Continuous
have
infusion.
frequent? Yeah. Okay,
Yes,
so
it's
you're
going to be
go to
continuous. So fentanyl also is continuous infusion. We're
Okay.
using that as a continuous infusion for sedation in the ICU, just prolonged sedation.
So again, to follow up on Muhammad's question, so I mean, aren't they in the same family? So technically speaking, because I think romafentanil is an isomer of fentanyl in a way. So based on that, I would think, logically speaking, the interaction could still take place with a serotonergic agent, just like fentanyl can cause serotonin syndrome.
Right.
Technically, romafentanil can cause. I just didn't know if you had any information
So
about that as well.
I don't have information about that, so I'm going to look into the evidence
Okay.
and see if I can find anything about remfentanil specifically.
And for the dex, when you're using that obviously as a sedative, you're right. But what if you